Hey guys, so this is my psychological report slash treatment plan for case number 5, which is for Victor. So, for identifying information, that would include confidential psychological evaluation report. Name is Victor Marchetti. Sex is male. Age is 24 years old. Date of birth is unknown. Race is Caucasian. Primary language is English. Report date is unknown. Clinician's name is not mentioned in the report, so I just put my own for this presentation. Victor was referred for outpatient evaluation by his parents. Victor's parents were concerned for his mental health. Victor would agonize over what he calls his thinning hair, scarred skin, uneven ears, and wimpy body. Victor's behaviors would lead to blading his skin with razors and compulsive picking of his skin. He would agonize about his appearance and believe that other people were mocking his appearance. According to Victor's parents, these behaviors became prominent at the age of 13. As mentioned earlier, Victor is 24 years old, therefore, the duration of these symptoms have occurred for 11 years. It's important to note that in terms of Victor's compulsive checking of areas that he dislikes of his body, this would usually occur 6 to 7 hours. So, for some background information, Victor was found to be a socially withdrawn and isolated individual. His delusions about how others perceive him have led him to distance himself from his peers. In addition, his compulsions would often interfere with his social and academic life. For example, Victor missed several months of high school because he was too preoccupied to do schoolwork, felt compelled to leave class to engage in body checking, and was too self conscious to be in the presence of his peers. His fixation on appearance led to having a rigid daily weightlifting routine. When going out, he most often wore several layers of t shirts to look bigger, and he would also wear a baseball cap or knitted hat to hide his ears and hair. Additionally, he would use protein powder to build up muscle. However, he denies using anabolic steroids or other performance enhancing drugs and substances. According to his parents, Victor does smoke marijuana and would drink. They believe this was Victor's way of self medicating for his chronic stress. One important thing to note is in terms of family medical history, Victor's mother was diagnosed with OCD. Again, his parents note that the earliest onset of compulsive behaviors that focused on self image emerged when Victor was 13 years old. Common concerns were that Victor would have about his appearance involved thinning hair, scarred skin, uneven ears, and a wimpy body. However, despite all these issues, Victor's appearance was considered typical by an outsider's point of view. However, Victor would not be able to see himself the way other people see him, and this would lead to constantly trying to quote unquote fix himself by using different methods such as blading his skin with razors, which was an attempt to clear his skin. He did see a dermatologist, but the appointment was found to be unsuccessful based on all the external behavioral issues. Victor explained that he would suffer from a depressed mood, experience feelings of hopelessness and worthlessness, um, trouble with concentration, and suicidal ideation, all of which attributed to the concerns over his appearance. So, based on the background information, which takes into account both Victor and his parents' accounts, I can conclude that the most accurate diagnosis would be 300.7 F45.22, which, according to the DSM 5, would be body dysmorphic disorder with absent insight slash delusional beliefs with muscle dysmorphia. Criteria for body dysmorphic disorder is criteria A, preoccupation with one or more perceived defects or flaws in physical appearance that are not observable or appear slight to others. Criteria B, at some point during the course of the disorder, the individual has performed repetitive behaviors such as mirror checking, excessive grooming, skin picking, reassurance seeking, or mental acts such as comparing his or her appearance with that of others in response to appearance concerns. Criteria C, the preoccupation causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. The appearance, for criteria D, the appearance preoccupation is not better explained by concerns with body fat or weight in an individual whose symptoms meet diagnostic criteria for an eating disorder. So for specifiers, for Victor would be with muscle dysmorphia, which is the individual is preoccupied with the idea that his or her body build is too small or insufficiently muscular. This specifier is used even if the individual is preoccupied with other body areas, which is often the case. Another specifier for Victor is with absent insight slash delusional beliefs. The individual is completely convinced that the body dysmorphic disorder beliefs are true. There is no mention in the original report of what mental status examination Victor was given. However, based on the examination results, Victor was all within normal limits except for the delusional beliefs about his appearance and ideas of reference that others take special notice in him and mock him. A specific example would be believing that other people gossiped about him or made fun of him because of his looks, or him being convinced that he looks repulsive. Um, Another thing to mention is his eye contact during examination was poor, mood was depressed with irritable affect. He admitted to frequent suicidal ideation without plan or intent. So for main objectives, number one, Victor will work with his therapist slash counselor in understanding the importance of behaviors he partake, how the negative behaviors he partakes in can be reduced and or avoided with other thoughts and behaviors. This education will occur every week and will be more defined within the first few weeks. Number two, no drugs will be used by Victor. Number three, new methods for alternative behaviors will be taught. And number four, Victor will have to confront his worries during socialization methods and social skill building. So these are some more specific objectives. Number one, regulate negative thoughts about self. This will mean monitoring moments where Victor has negative thoughts about himself that include mainly fixation on his appearance. And he will keep track of these negative thoughts. One way he can do that would be using a diary. He'd write his negative thoughts down, how many negative thoughts he has in a day or the week, and he could compare them. Number two, broaden ways of thinking about the self, challenge and counter negative thoughts with positive thoughts about the self. This could mean instead of thinking of what I think is wrong with my appearance, think about what you like instead. For example, Victor can focus less on I look repulsive and instead think about how great his outfit is. Number three, replacement behaviors, alternative behaviors that replace OCD behaviors in individuals with BDD. When the urge to blade skin occurs, find something else you can do to take your mind off blading skin. For example, instead of Victor blading his skin, he goes for a walk. Number four, build and focus on expanding on having new behaviors. Instead of Victor continuing old behaviors that are a concern, Victor focuses on building new behaviors. This can be learning something new, like a hobby, for example, fishing. Number five, in order to reach full success, Victor will need to remain sober. If his means of self medicating involves alcohol and smoking marijuana, he will need to learn how to be less dependent on using these type of substances. to reduce his chronic stress. So for interventions, there are many forms of treatment intervention plans for individuals like Victor who have body dysmorphic disorder. One popular form is psychotherapy. Within psychotherapy, there is CBT, cognitive behavioral therapy, that uses a variety of techniques such as exposure and ritual prevention, systematic desensitization, downward arrow method, self-confrontational techniques, and cognitive imagery. The focus on CBT is to identify maladaptive thoughts, analyze and evaluate these thoughts, and construct alternative thoughts that would end up replacing the initial maladaptive thoughts. CBT looks at core beliefs of the individual and attempts to reassess these thoughts. In the case of Victor, Victor's core beliefs include him believing that he is repulsive looking, which you mentioned earlier in the report. The down arrow technique would involve the therapist asking about a belief, like, what do people think of your appearance? The response in this scenario might be, it is scarred and therefore I am repulsive looking. That is one way of how the down arrow technique is used in CBT. For Victor, CBT should be 1 hour sessions that run 6 to 9 weeks. And if there is not much progress being made, then we can extend sessions to 12 to 14 weeks. An alternative is medication as well. Common medications include, but are not limited to, are selective serotonin reuptake inhibitors such as Celexa, Lexapro, Prozac, etc., lithium benzos. I put a star where it has medication because I think specific to this case, I don't think medication is needed, at least early on. I think that CBT is a better frontline treatment for Victor. And I will go into this in more detail later on in the presentation. General interventions would be meetings involving substance use, and then meetings or groups that focus on body positivity. So for interventions in relation to main objectives, number one, for the main goal, psychoeducation will be used consistently throughout every session, but more so within the first few weeks, such as weeks 1 to 3, which involve interview, assessment, and evaluation as well. Victor will learn about the effects of BDD and how these effects align with his own behaviors and how these behaviors affect his everyday life. While these discussions occur, the counselor and client will work together to work on an individualized plan with specific goals. The CBT sessions will include identifying maladaptive thoughts, and then the clinician will evaluate these thoughts. Another thing is that the patient will discuss core beliefs such as I am repulsive looking, and the patient will discuss this and evaluate this with the counselor. In order to reduce Victor's self-medicating techniques that include drinking alcohol and smoking marijuana, he will attend individual or group meetings, but if he prefers more privacy, he could also attend anonymous meetings such as AA or Marijuana Anonymous. So interventions in relation to main objectives number 3. As described in detail in this presentation, Victor will participate in CBT, where he will be taught alternative behaviors, new ways of thinking, and different positive coping skills that are meant to reduce or eliminate negative maladaptive thoughts, compulsive self-harm habits, and analyze delusional core beliefs with something that's more realistic. Victor will receive homework every week and will review past homework with his counselor. Goals can be adjusted accordingly throughout the weeks depending on how Victor is making progress. Confrontational techniques will be used as a means to help Victor reduce anxiety he has that is associated with his looks and how other people perceive him. Interventions in relation to main objectives number 4. As mentioned in the previous slide, Victor will confront his worries and fears that are based on his appearance and how other people perceive him. In CBT, techniques include exposure and ritual prevention. As mentioned in this presentation, one way Victor could use these techniques gradually would be to, for example, go into a store where he's not wearing something that covers his entire appearance and is something more fitted to him, um, where he would confront a stranger. So, how will these sessions go? So, typically, sessions will start with psychoeducation review of the past week. This is to go over symptoms and already signed homework. Then, agenda will be made. This is to collaborate to form a plan for the week. And then review and discuss homework. Homework will be discussed at the end of each session, and then there will be a Q&A where the counselor slash therapist will ask the patient if they have any questions, and then there will be a discussion about future sessions, talks about introduction to different behavioral techniques and how the patient can monitor negative thoughts. So how do we utilize new skills to reduce old core beliefs? So there's exposure therapy. What is exposure therapy? It is a gradual increase in anxiety-provoking situations. An example would be there was a similar example that I mentioned earlier. So Victor going out to a store in clothes that fit him. The exposure would be towards a stranger. Start gradual, then move on to friends and family and people he's more familiar with, which may be more anxiety provoking than someone he's probably never going to see again. Um, Response prevention is attempting to avoid giving a response to compulsive behaviors. An example would be Victor is at a family gathering or any gathering and he avoids leaving the room to check on his appearance. So after session 3 and onward, some things to keep in mind is, have the goals been met? Are the interventions working? How is the patient making progress? Has the treatment been successful? That's more towards the ending of all the sessions, which would then determine if termination should occur. So one thing I didn't mention is perceptual retraining, which is basically, for example, if Victor were to look at himself in the mirror every day as a task, and he would say something positive, non-judgmental, about his appearance, and will refrain from using negative comments about himself. So in terms of percentages, this can be found in everyone's DSMs. I just put this in just for extra information in case people were curious. The point per prevalence among US adults is 2.4% for body dysmorphic disorder. That is 2.5% in females and 2.2% in males. But again, this information can be found in your DSM. So I did talk about medication briefly earlier, but I'll go into more detail here. Victor is currently not taking any medications and he has no significant medical history, but it should be noted that his mother was diagnosed with OCD. Based upon Victor's parents' account, he drinks alcohol and smokes marijuana to relieve chronic stress, and his parents they believe that it's just his way of self-medicating. Um, Common forms of using medication for individuals with BDD is using SSRIs um, for uh, for individuals with BDD and OCD. However, there are other concerns that I think should be tackled first, especially in this situation or scenario. For example, Victor mentions experiencing depressive symptoms combined with feelings of hopelessness. I think it would be best to examine depressive symptoms further before settling on a medication to reduce BDD effects. CBT has been found to be effective, so I think counseling treatment should be the first line of treatment for an individual like Victor instead of relying on medication or solely on medication. So, based on how Victor responds on to CBT treatment, I think that based upon how he responds to it later on, medication can be discussed. But this would again depend on Victor's progress during counseling. I do not think that medication should be the first and only option to stabilize and reduce negative symptoms. So for adjunct services, Victor will attend individual counseling. However, he will also be given the opportunity to attend Alcoholics Anonymous and or Marijuana Anonymous for more privacy, if he'd like. If Victor attends these sessions, he will be required to receive a signature from the group leader or whoever is running the meeting. Victor does not need to visit his primary physician on a regular basis. However, follow ups with the counselor will occur 2 to 3 weeks after the final session. Follow ups are necessary to see if there has been a relapse and or if their treatment has been successful long term. So, recommendations for other stakeholders. Parties involved included Victor and his parents. Aside from those two parties, no other parties were involved, such as children, grandchildren, or friends or teachers. Victor is a competent adult. However, the accounts taken from his parents help define Victor's behavioral concerns. Communication between the counselor and Victor should be consistent. In order to monitor Victor's progress, there needs to be proper communication. Victor is not required to see his primary physician on a regular basis, as noted earlier, but it is good if he communicates with his primary doctor. If there are drastic changes in Victor's health, it's important that he relays this information back to his primary care. So for prognosis, based upon the patient information, Victor has an absent insight slash delusional beliefs where he is completely convinced that body dysmorphic disorder beliefs are true. However, aside from the above, Victor's overall being is fair. Despite having absent insight slash delusional beliefs, Victor has the capability to learn new techniques to reduce current behaviors associated with BDD, and this was reflected in his mental status examination, which was all within normal limits, minus the delusional beliefs. For risk and prognostic factors, in the DSM, it says that there are environmental factors. Body dysmorphic disorder has been associated with high rates of childhood neglect and abuse. And then there's genetic and physiological. The prevalence of body dysmorphic disorder is elevated in first degree relatives of individuals with OCD. Again, his mother was diagnosed with OCD, but according to Victor's family history, there is no indication of childhood neglect and or abuse. Noted age of onset was age 13. Victor is currently 24. For almost half of his life, he has had issues with his appearance. However, he has also had 13 years where he did not have any issues, according to his parents. Since these issues have not occurred throughout his entire life, there is some room and chance for positive change. So the couple of relapse prevention strategies, although not suggested for Victor, some studies suggest a continuation of certain medications like escitalopram medication, which delays relapse. Um, Another strategy is consolidation, which focuses on a plan for the future. Consolidation and planning involves the therapist asking about future changes or expectations the patient may have. For example, maybe Victor has a job interview. Consolidation allows the patient to utilize new skills taught in the future for expected or unexpected situations. In order to keep track, follow ups are done along with self therapy meetings to help prevent relapse under new situations that are, like I said, expected or unexpected. So, here are a couple of studies. The first one is by Prazers from 2013, and these studies are all they reflect the situation that Victor is in. So this study in particular reviewed the efficacy of different methods of cognitive and/or behavioral therapies used to treat body dysmorphic disorder. The type was a meta-analysis, and the data, all studies published concerning the treatment of BDD up until July 2012, including individual CBT, group CBT, behavior therapy, cognitive therapy. And based on the results, the most improvement involved CBT, which was recommended for Victor. Here, individual and group CBT were found to be the most improved, which had empirical positive effects on individuals with BDD. The second study is by Wilhelm from 2014. The objective was to analyze and examine the efficacy of a manualized modular cognitive behavioral therapy for individuals with BDD. It was randomized. There were 36 adults involved with BDD. They were randomized into 22 sessions of immediate individual CBT BDD sessions, and the duration was 24 weeks. So, based on the results, improvements were made in the following areas: depression, insight, and disability. Patients were very satisfied with the effects from the sessions. As mentioned earlier in Victor's situation, he did note depressive symptoms, and in this study, CBT was found to be very effective in areas of depression. So, in this last study that I'll talk about, the objective was a systematic review and meta analysis on the impact of CBT, the impact that CBT has on individuals with body dysmorphic disorders. Basically, in this study, it was a review of previous studies that have been done. They were all randomized control trials, some of them were unpublished, and they would look up these studies all the way up until the 26th November 2015. And what they found across the studies was that treatment gains were maintained 2 to 4 months after CBT trial. There were improvements in areas of depression, and CBT for individuals with BDD had a large size symptom improvement. Again, this reflects the two previous studies that I mentioned, and this also reflects a lot of the issues that are associated with Victor's situation and case. So I thought that all three studies were appropriate. So that's the end of my presentation, and if there are any questions, then please leave a comment under the video when I post it. Thank you.